Head of the Department of Pediatrics at Travancore Medical College. I now call upon Dr. Shimi to give the presidential address.
Thank you, Dr. Goviman. Our chairperson for the TIPPS in office practice for house surgeons, Dr. Johnny, and the secretary, Dr. Govi Mohan. Faculty for today, Dr. Virendra sir, as well as Purushothaman sir, who's joined us today, and all the house surgeons and all those who have joined us today for this program. Definitely the teaching of a house surgeon regarding certain topics are very useful, especially in a office practice, because most of the time the house surgeons are the people who are there at night when these kind of cases come. So to update them on what is happening and what is to be done is most important, because we cannot, because many a times they might not be accustomed to what is the situation, might not have an idea of what is to be done. So to have an update on that, that is why we have gotten the best of the speakers as we are going through. Last week we had on neonatology aspect, but this time that is why we have got the same talk on snake bite, which is very common in Kerala, but scorpion at times in Kerala, but I think so in other states also you get scorpion. So if anybody sees a bite should be aware of whether it is a scorpion bite or it is a snake bite and how to handle it. That's the most important part. And I think so we have a good faculty today. Dr. Virendra sir is there to highlight on that part. So wishing everybody a happy learning today, and Jai AP, Jai. Thank you. Over to Dr. Govi Mohan.
Thank you, Simi, for the presidential speech. It gives me an immense pleasure today to introduce my HOD, Dr. Virendra Kumar. Sir did his MBBS from Government Medical College, Kottayam in 1986. His DCH from SAT Government Medical College, Trivandrum in 1989. His MD Pediatrics from SAT 1990 and retired as a professor from Government Medical College, Kottayam. He has a very vast experience in teaching the UGs and the PGs, and now working as a professor and HOD, Travancore Medical College, Kollam. Excellent physician, excellent clinician. It's a pleasure to have Virendra Kumar sir, who will be talking on snake animation and scorpion bite approach. Thank you.
One minute.
Sir, share your answer.
Shall I start?
Yes, sir.
Okay. So I will, first of all, I am expressing my gratitude to the IAP office bearers for giving me an opportunity to make this presentation on these two common topics, snake envenomation and scorpion stinge. I am wishing a good evening to all honorable IAP members, my teachers, faculty, colleagues, and students. So I am going to share the screen. Okay, can you see?
Yes, okay, go ahead.
Snake envenomation and scorpion stinge. First, I will talk about snake envenomation. That is a most important topic, and it is a neglected tropical problem, tropical disease, a neglected tropical disease, because even now more than 50% of deaths in India due to snake envenomation every year. 3% of this is under 15 children, and 77% of deaths occur in out of hospital setting before reaching the hospital. Even if 50% of bites only will have envenomation, the remaining 50% of bites are either dry bites or non-venomous snake bites. We have a polyspecific anti-venom, ASV, which is effective against the big fours. What are the big fours? Cobra, crate, and two species of viper, Russell's viper and Ectis carinatus. One caution is there is a hump-nosed pit viper which is also pathogenic. Hump-nosed pit viper venom also is toxic. It can cause death also. Anti-venom will not cover that. That we have to take care. And there is a king cobra bite, which is also envenomation, which will not come under the current polyspecific antivenom. But king cobra bite is not practically important because they are mainly forest dwellers and large snakes. Accidental bites will not occur in case of king cobra, very rare. But humble-nosed pit viper are very common in our human habitat, which can produce death and morbidities also. So it is a neglected tropical problem, snake envenomation. So how will you approach it? What is the, it is due to the lack of awareness this death occurs. Late coming to the hospital, late arrival, and not timely giving the ASV, timely resuscitation. It requires an ICU care, intensive care, timely referral. Even sometimes the referrals are not adequate. There should be, and as far as possible, ASV should be given in an envenomation in the golden hour itself. Once the venom is fixed, there is no role for only free-flowing venom will be neutralized by the antivenom. So antivenom will not be effective once the venom is fixed in the tissues. So the time is very important. The first 1 hour of any envenomation is very important. So timely management and timely giving ASV, timely supporting care. Even if you are referring, that also should be proper. A distant referral without any medical support, without an accompanying doctor, also will lead to deaths. That is why the deaths are there. Even there is a effective ASV is there in India, covering most of the poisonous bites. So how will you decide envenomation? That is the one thing we have to identify. In every bite, it can be snake bite or it can be unknown bite. We don't know whether it is snake or not. What is the aim of a medical officer is identify envenomation. There are 3 types of envenomation: local reactions, CNS manifestations, and vasculotoxic manifestations. Depend upon the protein component of the venom in each snake. The manifestations can be cytotoxic manifestation of the local reaction and CNS or vasculotoxic manifestations. So we have to identify, is there any local reaction, any CNS manifestation, or any vasculotoxic manifestation. That is the way we have to pick up an envenomation. If there is envenomation, it has to be treated as early as possible. With that message, we are going. How will you identify a bite? It can be a bite, a non-snake bite or an unknown snake bite. Even if it is a non-snake bite, only 50% will have envenomation. Majority of the biting snakes are non-venomous. Only 30% is venomous. So even in the venomous bite, it can be a dry bite, or adequate venom may not be injected into the prey. So a bite, we have to observe. We should not send any bite without observation, and observation should be 24 hours observation. There can have late envenomation also. So second is bite with a local reaction. A local reaction means just a swelling is not a local reaction. It should be a painful progressive swelling. And also there should be 3 B's: bulle, blubber, bleeding, blisters. These are the local reaction, not a just swelling. It should be progressive swelling. It should cross one joint or more than half of a limb. That one, progressive swelling, is a significant local reaction. If there is a local reaction, it is a viper bite or a cobra bite. Crate bite will not produce any local reaction. The next is a bite with local reaction and neurological symptoms. What are the neurological symptoms we have to look? The neurological symptoms mainly in the eyes. Ptosis is the first neurological symptom. Next is the ophthalmoplegia that can produce diplopia. Then there is descent into the pharyngeal muscles, laryngeal muscles, and intercostal muscles. So it is a descending Guillain-Barré-like presentation. Start with the eyes. So neurological symptoms start in the eyes. Bite with the local reaction and neurological symptoms is cobra bite. We need not see the snake. We need not ask for seeing the snake. From the symptoms, we can identify. These are the syndromic approach. So a bite, which can be known or unknown, a bite with a local reaction, significant local reaction, that is an envenomation. That requires an ASV. Treatment is required. Then bite with the local reaction and neurological symptoms. Then the ASV administration is a little different. Supportive care in the form of ventilation is more required. Next is bite without a local reaction and neurological symptoms. That is the great bite. The importance of great bite is that the neurological symptoms are the toxin of a crate will act on the presynaptic neurons. Presynaptic neurons, AS will be a little less effective. Only the free-flowing AS will be neutralized by the free-flowing venom will be neutralized by the ASV, and full recovery will not occur. It will take time. So ventilation may be required in a crate bite, that is without local reaction. Then bite with local reaction and vasculotoxic symptoms. Vasculotoxic symptoms are the hemorrhage, shock, etc., where the venom act inhibits the coagulation factors. Depend upon the effect of the venom on coagulation factors. It can be a bleeding, or it can be procoagulant also. There is disseminated intravascular coagulation and consumptive coagulopathy and thrombocytopenia also can occur. And also the venom is toxic to the endothelium. That is also vasculotoxic. So a bite with a local reaction and vasculotoxic is viper. Russell's viper or Echis carinatus. Russell's viper is the commonest type of viper bite in Kerala, and also viper bite is more common than cobra bite in Kerala. And the one word about Russell's viper is that this viper venom can produce capillary leak syndrome also. That increases the mortality, 50 to 60% mortality in Russell's viper bite if the venom is not neutralized with an ASV timely. So bite with the local reaction and vasculotoxic is viper bite. Then occult snake bite. They're only descending type of Guillain-Barré-like presentation with ptosis, diplopia, dysarthria, dysphonia, dyspnea, dysphagia. That symptoms are there. No bite symptoms are there. No bite marks are there. No local reaction, because crate will not produce any local reaction. No lymphadenitis. The fangs of the crate is very slender, so the bite mark may not be seen. But in that case, we have to suspect in a descending Guillain-Barré with two features: abdominal pain and vomiting. Abdominal pain and vomiting are gastrointestinal systemic manifestation of non-specific systemic manifestation of envenomation. So the occult bite also has to be identified, especially in crate bite. That occurs night in floor-lying children. It can bite, and in the morning the child will be presented as a locked-in child. Child is not speaking, not respiratory difficulty, not opening the eyes, a locked-in syndrome. That presentation we have to suspect crate bite, especially if there is vomiting and abdominal pain. So these are the presentations by we have to pick up an envenomation. By local reaction, CNS manifestation, that is starting from the eyes, vasculotoxic manifestation with hemorrhage and BP fall, then occult snake bite with the CNS manifestation and abdominal pain and vomiting. Then how will you manage? You identified a child is brought with a snake bite. In the emergency, how will you manage? Do it right. That is the word. This is the word given by, coined by WHO. RIGHT. Right is, R is reassurance. Reassure the parents and reassure the child that is majority of the, even if it is a poisonous bite, it will not produce envenomation in 50%. There is effective treatment for that. That is reassure. You have to reassure. Then immobilize. Immobilization is very important. If the child is active, then there is rapid absorption of the venom. So you have to immobilize the bitten limb. Immobilization can be pressure immobilization with elastocreep bandage, but too much pressure should not be used, and tourniquet should never be used. If there is no elastocreep bandage, just immobilize the limb, decrease the activity of the limb. Can you wash the limb with soap and water? No. Washing with the bite side with soap and envenomation, that also should not be done. Then no cutting and incising the wound to let down the venom. That also should not be done. Do not waste time for other modalities of treatment. Go to the hospital. That is the next G of the right. And tell your doctor all details. This is the first thing. If there is a snake bite, it has to be done. This is pressure immobilization with elastocrete bandage. It should not be too tight. You should be able to introduce a scale through the elastocrete bandage. It should only obstruct the venous drainage and the lymphatic drainage. Should not obstruct the arteries. This is the way you can transport to a hospital if a vehicle is not available. If a bike is enough, but the bitten person should be kept in between, in the middle. Then what? Tourniquet, you should avoid a tourniquet. It causes gangrene. If the child come with a tourniquet in the emergency, then you should not remove the tourniquet then. If sudden removal of the tourniquet can produce massive neuroparalysis and hypotension. Be careful. If come with the tourniquet, do not remove the tourniquet. Only after starting the ASV, you remove the tourniquet. But it's only local reaction, no systemic manifestations, no CNS symptoms, no coagulopathy. Then after starting an IV access and an IV fluid, you can remove the tourniquet. But don't put the tourniquet by yourself. Yeah, how will you assess? History of the bite, when bitten, where bitten, what is the time, what are the symptoms, the local site for progressive painful swelling, which crossing the limb. That is a local envenomation. Bleeding, bloods and bullae, tender regional lymphadenitis, that also early occurs in envenomation. Then systemic features by respiratory rate, pulse rate, BP, capillary fill time. Then bleeding from any site, oral bleeding, nasal bleeding, any site, or bleeding from the local bite site. Then CNS manifestation starting with the ptosis. You can also, in older children, single breath count. As by a single exhalation, the child can count, in an older child should be able to count up to 25 to 30. Single breath count is an easy identification method of respiratory symptom involvement. Sometimes there are capillary leak symptoms, that is chemosis, conjunctival edema, and parotid enlargement, periorbital puffiness. That is an indirect evidence of capillary leak. If snake being brought, do not touch, even if the head is severed. Treat the patient, not the snake. We have to identify the envenomation from the syndromic approach, from the symptoms. That not by identifying the snakes. Snake identification is not required. What all investigations will you send? Investigations mainly for vasculotoxic envenomation. Before overt bleeding, we can pick up coagulopathy by whole blood clotting time. That is a easy test that can be done even in a primary health center. 20-minute WBCT. That is called whole blood clotting time. 20 minutes means just blood, 2 to 3 ml blood is taken in a sterile test tube, in a dry, clean test tube. It should not be washed with detergent. If washed with detergent will inhibit the surface acting factors. So the clotting time can be prolonged. It should be a dry one. Even if an old test tube is reused, wash with saline and air dry. Do not wash with the detergent. 2 to 3 ml blood taken and keep for 20 minutes. Till 20 minutes, if it is not free flowing, then not clotted, that is whole blood clotting time is prolonged. That is, there is systemic envenomation, vasculotoxic. This has a sensitivity of 75 to 80% and a specificity of 90%. The sensitivity can increase by additional tests which may not be present in all primary health centers. PT-INR. PT-INR more than 1.2 increases the sensitivity. That will be early affected than the whole blood clotting time. But the reverse also can occur. PT-INR can be normal. Whole blood clotting time can be prolonged also. That depends upon the type of the proteins in the venom. Some of the venom adds certain coagulation factors which will not affect the PTANR. So whole blood clotting time can be prolonged with normal PTANR also. So whole blood clotting time always should be done. PTANR will increases the sensitivity. Fibrinogen also will increases the sensitivity. Decrease the fibrinogen will help fibrin degradation products will indicate microangiopathy, disseminated thrombosis. Then another evidence of systemic envelopation is leukocytosis and thrombocytopenia. So there is a role for CBC also. Then RFT and electrolytes for comorbidities, acute kidney injury, hyperkalemia due to the tissue necrosis and kidney injury, CPK, rhabdomyolysis, CPK will be very high. If the CPK is more than 5,000, 10,000, we will think of a rhabdomyolysis. Rhabdomyolysis will affect the outcome also, can produce acute kidney injury. Then glucose, GRBS, that can be reduced if there is an adrenal hemorrhage or pituitary bleed. So the investigations, whole blood clotting time is the most important investigation. The sensitivity you can increase by adding PTANR, CBC, RFT, electrolytes, CPK, and glucose. These are the minimum investigations required. Then there is an isolated bite, no local reaction, no systemic manifestations. Can you send go? No, I already said, keep under the observation for 24 hours. Look for any sign of envenomation. Then how early and signs of envenomation can develop? The earliest envenomation evidence is viper, that will take 15 to 30 minutes. Cobra will take 30 minutes to 6 hours. Crate is little later, 6 hours to 24 hours. Rarely symptoms can take 24 to 36 hours. So majority 24 hours we have to observe for envenomation. Then only we will send the home that there is no envenomation. So 24-hour period observation is a must. Do not send prematurely, that saying that there is no envenomation. Local signs of envenomation I have already described. Swelling which is painful and progressive, crossing the limb, more than half of the limb or crossing a joint. Increasing local pain, tender lymphadenopathy, and bleeding, blister, bulle formation. And note that crate bite will not have any local reaction and it is painless also. These are the bleeding, blister, bulle, and the bite marks, 2 bite marks. Don't misinterpret. 2 bite marks need not be always there. Sometimes one fang only have bitten the prey. So 1 bite mark also can occur. 2 bite marks need not be there. No local reaction also there. That is can be crate. So carefully look for CNS manifestations. That is one which can miss. Then systemic signs of envenomation. Overt bleeding is a systemic sign. If not overt bleeding, by whole blood clotting time more than 20 minutes or PTANR more than 1.2. Thrombocytopenia less than 1 lakh. Leukocytosis and thrombocytopenia in CBC is a sign of systemic envenomation. Then GI symptoms I have mentioned: nausea, vomiting, and abdominal pain. This is a GI symptom which is seen in crate. In crate bite, it is important. Help envenomation in crate bite, and also in occult bite, this will help a clue. This will be a clue for a snake crate envenomation. Then in CVS, dizziness, hypotension, arrhythmias, CNS doses of thalmoplegia, descending paralysis. Then acute kidney injury and capillary leak syndrome. Capillary leak syndrome is rare, but mortality increases in that. That is seen in Russell's viper. This is 20-minute whole blood clotting time, test tube. And if test is normal, 2 to 3 ml blood is required, tilt the tube at 20 minutes only. Do not repeatedly shake. That will affect the clotting also. At 20 minutes, you tilt, clotted or not clotted. If clotted, repeat every hourly for 3 hours, then 3 hourly for 3 times, then 6th hourly for 24 hours. So even if it is normal initially, it has to be repeated hourly for 3, then 3 hourly for 3, then 6th hourly. One word of caution: do not use plastic or polypropylene or polystyrene tubes for testing whole blood clotting time. It should be glass tube, and glass tube should not be washed with a detergent. Can reuse ordinary glass bottles or antibiotic bottle after cleaning with a normal saline and air dry. If any evidence of envenomation, should we refer without ASV or after giving ASV? Is there a chance for reaction? Can we prevent it? Should we refer without ASV? If there is ASV in your facility, you should give ASV. Then only refer. While reference, you should accompany the child with all facilities for resuscitation and also facilities for treating anaphylaxis. That is the second question. Is there a chance of reaction? Yes, there is a chance of reaction. The chance of reaction is as high as 80%. So much chance of reaction is there. Can we prevent it? 50 to 55%, it can be prevented by preventive dose of adrenaline. That will come. What is the preventive dose of adrenaline? ASV is the specific treatment. What all ASV will do? ASV will stop the spontaneous bleeding in 15 to 30 minutes after administration of ASV. By 30 minutes, spontaneous bleeding will stop. But caution that whole blood clotting time will not be corrected. That has to be corrected only by increasing the coagulation factors. So liver has to do that. That is not the ASV role. Spontaneous bleeding will stop. Whole blood clotting time will take 4 to 6 hours. Average 6 hours. So we will repeat only after 6 hours. Shock will be corrected. Arrhythmias will be corrected in 30 to 60 minutes. So in the first 1 hour, spontaneous bleeding will stop. Shock will stop. Arrhythmias will stop. Neurotoxic envenomation will improve in the case of cobra bite. Post-synaptic envenomation, 50% improvement will occur in the first 1 hour. But pre-synaptic envenomation, crate bites and some sea snake bites are pre-synaptic envenomation. Russell's viper also has a pre-synaptic effect. That will take more time for correction because the body has to regenerate the vesicles. ASV has no role on pre-synaptic envenomation. Free-flowing venom will be neutralized by the ASV. So progression will be affected. So the full recovery will not occur in pre-synaptic envenomation. Example is crate and sea snakes and Russell's viper. But cobra bite, there will be dramatic improvement within 30 minutes to 1 hour. So these are then active hemolysis, rhabdomyolysis will settle in a few hours. Urine color also will normalize. Then coagulopathy, 20 WBCT will normalize in 3 to 9 hours, but that is 6 hours average is required. That will not so fast correction. Spontaneous bleeding will stop, shock will be corrected, arrhythmia will be corrected, post-synaptic CNS symptoms will be corrected in 1 hour time. Hemolysis and rhabdomyolysis will correct in a few hours. So urine color also will normalize. What ASV will not do, will not prevent. It will not prevent local swelling. Venom, fixed venom will produce local tissue necrosis. So that cannot be prevented by ASV. And progression of the swelling also cannot be prevented by the ASV. It will not reverse the AKI. That is due to the fixed venom. The fixed venom cannot be neutralized by ASV. And coagulation reversal, coagulopathy reversal, bleeding will be reversed. That is what liver does, not the ASV. Reversal of the presynaptic envenoming also ASV will not do. Nerve damage is structural. Body must regenerate the synaptic vesicles. Then ASV reaction as high as 80%. The most important ASV reaction is early anaphylactic reaction. Early anaphylactic reaction is complement-mediated IgG. It is not IgE-mediated type 1 hypersensitivity. So test dose has no role. It only wastes the time. And sometimes test dose can sensitize also. So that should be avoided. Early anaphylaxis is IgG-mediated, complement-mediated IgG. And also direct ASV stimulation of the mast cells. Early anaphylactic reaction can be prevented by adrenaline and also treated by adrenaline. Pyrogenic reaction is due to the contamination and late serum sickness after 1 day to 12 days presenting with vomiting, diarrhea, lymph node enlargement, and arthralgia. Most important is the early anaphylactic reaction in our management. What will prevent? I said we can prevent 40-50% of ASV reaction by adrenaline. There are studies for that. But never add hydrocortisone to adrenaline. If you add hydrocortisone as a preventive step, it will negate the effect of adrenaline. The prophylactic dose of adrenaline is half the therapeutic dose, that is 0.005 milligram per kg subcutaneous route. Therapeutic dose is 0.01 milligram per kg and it's intramuscular. So it is half of the dose subcutaneously. Never add hydrocortisone. If anaphylaxis occurs, then 1 in 1000 adrenaline, 0.01 milligram per kg intramuscular. We need not wait about the child in a critically ill child. For an infant, give 0.1 mg, child 0.3 mg, adolescent give 0.5 mg. This fixed dose also you can give. Infant 0.1, child 0.3, adolescent 0.5. Repeat ASV if needed. If anaphylaxis occurs, if adrenaline can be repeated every 5 minutes for 3 times. Still not corrected, you can give adrenaline infusion. The ASV, regard about the ASV, that is the specific treatment. What ASV, how do you give ASV? There are 2 types of ASV, liquid forms and freeze-dried forms. Liquid form, we have to keep the cold chain. It should be kept at between 2 and 8 degrees centigrade. And shelf life is only 2 hours. Freeze-dried venom has 5-year shelf life. You can keep in room air. So most of the hospitals, we are using freeze-dried ASV. Freeze-dried ASV is comes with 10 vial of 10 ml ampule of distilled water, sterile distilled water, sterile water also. That is for reconstituting the freeze-dried venom. So it will be reconstituted with all sterile precautions, reconstituted with 10 ml of distilled water. The final preparation should be clear. If it is opaque, it should be discarded. So initially, we will give 10 vials of ASV. 10 vials, 1 vial when reconstituted becomes 10 ml. So 10 vials means 100 ml. 100 ml of ASV, we will give with 5 to 10 ml per kg normal saline. Mix with 5 to 10 ml per kg normal saline. For a 10 kg child, requires 50 to 100 ml of normal saline. To that remaining part of normal saline, we will discard, and this 100 ml normal saline, add the 100 ml ASV and give in 30 to 60 minutes. While preparing the ASV, we have already given the prophylactic dose of adrenaline. If any reaction occurs during ASV administration, doctor should be there. Monitor the child with heart rate, respiratory rate, pulse rate, everything. You have to monitor the child. Look for any anaphylaxis. Any anaphylaxis occur, give adrenaline, repeated dose adrenaline or adrenaline infusion. As far as possible, finish ASV in 30 to 60 minutes. That will reduces the chance for infection, and further reaction we can manage. ASV anyway we have to give. 10 vials, that is the first. If after 10 vials, we will assess by 1 hour. What all things, if not corrected, we should repeat another 10 vials. That is persistence of shock. And also continued spontaneous bleeding. Spontaneous bleeding not stop. If it should subside within 1 hour, shock also should subside within 1 hour. If both not corrected in 1 hour, we have to repeat 10 vials of ASV. So 20 vials now we have given. Neurotoxic symptoms, if not improved by 50%, then also we have to repeat ASV 10 vials. For neurotoxic envenomation, 20 vials is the maximum. That is enough. More vials are not required. If CNS symptoms not corrected, it is usually great. Then respiratory support. Give respiratory support in the form of ventilation. Then, if that bleeding is corrected, overt bleeding is corrected, coagulopathy will take 6 hours to correct, minimum, average. So we'll see WBCT after 6 hours. If WBCT is not corrected, we have to give ASV. There we can use either high dose or low dose as per the current WHO recommendation, so that we can save ASV vials, which is a very life-saving medicine. We can give minimum number of ASV to correct the coagulopathy. So high dose regime means 6 vials every 6 hours. Low dose regime, 2 vials we will give every 6 hours. So in a neurotoxic envenomation, First 10 vials, if no improvement, we will give another 10 vials in 1 hour. In vasculotoxic, first 10 vials we will give. Then if bleeding not corrected or bleeding, no shock not corrected, after 1 hour we will give 10 vials again. But if bleeding and shock corrected, whole blood clotting time we will see at 6 hours. If at 6 hours, if whole blood clotting time is prolonged, we will give 6 vials or 2 vials every 6 hours, monitoring whole blood clotting time. When clotting time is corrected, we will stop ASV. We will not give maximum number of ASV required is 25 vials to 30 vials only. Never give more than that. More than that is not required. Even if a bite injected maximum venom in a sac, that can be neutralized by 30 vials of ASV in a vasculotoxic envenomation. Neurotoxic envenomation requires maximum 20 vials. If more than 30 vials, only WBCT prolonged, no overt bleeding, it may be a pit viper, hump-nosed pit viper bite. Only if there is bleeding, give FFP. Otherwise, for coagulopathy, WBCT prolongation alone, never give FFP. If late arrival in the hospital, then we need ASV. If WBCT is prolonged, give ASV. If there is neuro symptoms, give ASV. Otherwise, only supportive care. Only after full ASV, if there is overt bleeding, use FFP. For prolonged WBCT or prolonged PTINR without overt bleeding, FFP is not required. This is the hump-nosed pit viper. This you can, if brought, you can see it has a pointed snout, a little raised snout also. And also the dorsal scales are fused together. You cannot separately see the dorsal scale. This is the hump-nosed pit viper, just for identification. You see. Then supportive care, fluid support, to correct the euvolemia, inotropic support if needed. If not breathing, we have to give respiratory support in the form of positive pressure ventilation. Positive pressure ventilation, all these 3 ways you can give, or through the ventilator also you can give. Then what about atropine and neostigmine? It is a bridging therapy. CNS symptoms are not corrected. Before ventilation, preparing for ventilation, we can try atropine plus neostigmine. 0.05 milligram per atropine and 0.04 milligram per kg neostigmine intravenously. Observe for 30-60 minutes. Observe for 1 hour. If there is 50% response, you can repeat dose of neostigmine every 2 to 4 hourly interval. This is effective only in cobra. In crate bite, presynaptic envenomation, this will not be effective. This is only an interim therapy, not a major therapy between ASV and ventilation, to save the time, to bridge that time. Carry home message is history of bite, observe for 24 hours, never discharge. If envenomation, do it right. Do not waste time in the other modalities of treatment. Do not waste time in ASV test to dose. If ASV available, start, even if referring, start ASV and refer with ASV and an IV line, accompanied by, you should accompany the child and refer to the nearest hospital, never refer to a distant hospital. Adrenaline prophylaxis reduces the reactions, and effective use of adrenaline will also treat the reactions. Never refer without stabilization and unattended. Refer to the nearest hospital, and it requires an ICU care. Monitoring is required. Constant monitoring is required. During giving administration of ASV, doctor should be there bedside. That is the carry home message. This is all about snake envenomation. Shall we discuss in the end after the scorpion bite?
Yes, sir.
Yes, that will be better, sir.
Okay, next is the scorpion bite. Scorpion bite is not that much important in Kerala because the poisonous scorpion is Indian red scorpion. Black scorpion is the predominant one in Kerala. There are red scorpion also, but the scorpion envenomation is more in Maharashtra, Telangana, Karnataka, Tamil Nadu, less in Kerala. Before alpha blocker prazosin, that is the one that in use of prazosin will reduce the mortality of snake envenomation from 30% to 1 percentage. So that is the one that is most important, alpha blocker prazosin. That is not a very costly drug that will reduce the mortality in scorpion bite. There is a scorpion anti-venom, as in the case of ASV, scorpion anti-venom is there. But that is not required. That will a little earlier reduces the symptoms. Prazosin will take a little more time, but the final outcome, mortality, everything is same whether you use prazosin or anti-scorpion anti-venom. The venom, the most important is an alpha toxin component of the venom. That is a neurotoxic. That venom will affect the sodium channels, voltage gated sodium channels. So there is hyperpolarization and suppression of the potassium channels that will produce an autonomic storm. Initially, there is a parasympathetic or cholinergic storm followed by a persistent adrenergic storm. Finally, there will be myocardial dysfunction and vasoplegia. It is time bound. Initially, 30 minutes scorpion bite can be asymptomatic. If it is a poisonous scorpion bite, there will be pain and the pain will be progressive. In an unknown bite, we don't know whether it is scorpion or wasp or bee or snake bite. What will you do? What is the marker for a scorpion bite? That is a tap sign. You tap over the bite mark. There will be shooting pain. That is called a tap sign. If tap sign positive, it is likely scorpion, not a wasp or a bee. Snake envenomation, there will be progressive swelling, bleeding, blistering, bullale, etc., lymphadenitis, but that will not occur as a local symptom. There will be swelling and progressive pain. Tap sign will be positive. But for local symptoms, we need not give prazosin or anti-scorpion envenomation. If there is a autonomic symptoms, we have to give prazosin or anti-scorpion envenomation. Prazosin enough for us that you can manage it very well. Symptoms will occur usually by 4 to 6 hours, autonomic symptoms. But in children, it can occur earlier. By 30 to 45 minutes, autonomic manifestations can occur in children. Early manifestation. What are the early autonomic manifestations? Early autonomic manifestations, I said it is parasympathetic or cholinergic. So there will be profuse sweating, excessive salivation, meiosis in a male child, priapism. These are the bronchospasm, bradycardia. These are the early manifestations. It is followed by hypertension. And hypertension can produce flash pulmonary edema due to the adrenergic activity. So that is the indication for drug treatment. Prazosin is the drug treatment, but never give is a sustained release prazosin should not be given. Only it's a short-acting prazosin. Prazosin is available as 1 milligram tablet or 2 milligram tablets are available. Short-acting preparation should be used, and you can give it crushed if the child cannot swallow, and through the rice tube also you can give. And after one dose of prazosin, wait for one hour, wait for 2 to 3 hours for decrease in the autonomic symptoms. BP has to decrease, tachycardia has to decrease, BP has to normalize, and extremities should be warm. So autonomic symptoms should settle by 2 to 3 hours. If not settled, you can repeat the dose at 3 hours. Then every 6th hourly, you can repeat 30 microgram per kg per dose. Maximum 4 or 5 doses are required by which you can correct the symptoms. Yes, anti-scorpion venom is not much needed. If only local symptoms, what you can do? You can do oral paracetamol. Paracetamol you can give oral or suppository 15 mg per kg. Then topical anesthetic, MLAP, that is a combination of lignocaine and prilocaine that you can apply. Avoid as far as possible lignocaine injection. But if you are giving a lignocaine injection around the bite site, careful that it should not contain adrenaline. That can produce necrosis, and also adrenaline can increase the autonomic storm. And never give steroids also. And cold compresses also will reduce the pain. Look for autonomic manifestations. Early autonomic manifestation is sweating and sialorrhea, meiosis, bronchospasm, etc., parasympathetic manifestation. Then BP increase, pulmonary edema. Then other supporting care, adequate fluids, oral fluids are enough. Only if oral fluids cannot be taken, IV fluid give. Then monitor the child if there is myocarditis, dobutamine, and other supporting measures in the form of nitroprusside, nitroglycerin. Prazosin is the alpha-1 blocker. That is the mainstay of treatment. Indian scorpion antivenom, SAV, scorpion antivenom. That neutralizes the red scorpion venom. Dose is 3 vials SAV, that is 30 ml, mixed with 70 ml normal saline. And it should be given in the first 6 hours. The only final outcome is same. The early resolution of symptoms only will be there. Okay, that is all good about scorpion bite also. Thank you.
Thank you, sir, for that crisp and informative talk on envenomation and scorpion bite. I now request Purushottam sir to give his valuable input. Purushottam sir.
Thank you, Virendra Kumar. Excellent talk as usual. Just share a few experiences. We have in Thrissur, we were working since late 80s onwards. At that time, many cases were coming from Attapadi, Palakkad, where this anti-snake venom was not available, and by the time they all die by the time, 2 hours, 3 hours, or renal failure and complications. That was a time when very bad experiences. And regarding the scorpion, during our childhood, we never had any bad experience with scorpion. I never thought a child with the scorpion sting will die. So that was an experience in 90s. We lost 2 kids. We didn't know what was going on. This sort of a systemic manifestation following scorpion was not an experience earlier than that. Even during my postgraduate period in Calicut in the mid-80s, we never experienced a scorpion bite causing. But in 90s, 2 cases died, and exactly what Virendra sir was saying, autonomic storm, the wide fluctuation of BP going very low to very high, tachycardia, bradycardia, and glucose hyperglycemia, potassium changes, and patients were dying. And after this thing, we came to know that in Pondicherry, Andhra Pradesh also, the scorpion is very common, and the death were all due to the red one, where you see the tail, unlike the dark one, where the limbs, legs are, and it looks much more frightening, but the red ones seem small limbs, but the tail is large. So they are the most dangerous ones. There they use prazosin, and the case report was there in IP, Indian Pediatrics. And after this, we had scorpion stings, but no deaths after that. So I had deaths before the prazosin only. Once this prazosin, there were cases, but no patient died of this thing. So simple, or we were not happy about this thing. Whether prazosin is an alpha blocker that will lead to hypotension, a little bit of a doubt was there. When the patient is going into hypertension followed by a low BP, will it do harm? Actually, no. You should be giving prazosin. So that is an experience. And about the other snakes, as sir was pointing out, one very important missing is crate always. Crate has got a habit of coming indoors. They like to stay with us. So bed actually, if you are lying on the floor, they develop a device. The mosquito net should be tucked into the beneath the bed. Otherwise, they can give bite. There won't be any pain. The sting mark, the bite mark won't be visible. And one case, abdominal pain, admitted in pediatric surgery. Actually, we are about to go for laparotomy, and patient doses was missed because it was taken as a sleep. So very important, abdominal pain with doubtful toes is always considered to this is very eminently treatable this crate bite. Another one, it is not the neurotoxic, purely neurotoxic cobra crate situation, but in Russell viper also, it's a combination. All the other viper, like sir said, Echis carinata is the other viper, which is not that rampant here. It's certain areas only. Echis carinata is the saw-scaled viper in Palakkad. Certain other areas only this Echis carinata is seen. And the Malabar pit viper is there. And the hum-nose viper is so common here. So you all should be downloading two apps in the mobile. One is the Snake Pedia app, Snake PEDIA app, and Sarpa app. Sarpa is from the Forest Department. Snakepedia, our group of few of our experts developed, and I was a part of it. So it's a very good app. You can see many original pictures of these snakes and these poisonous and non-poisonous mimics. See, there are few snakes which look alike, like the viper-like non-poisonous are the Eryx cornicus will say. The crate-like things are lycodon. You call it a bald snake. So there are many cases we are administering anti-snake venom in case of these the lycodons, all the bald snakes. They look alike. So all these things you can confidently make out with that pictures. The two apps, both are very good apps. So the crate bite, very important, it should not be missing. And one very important point, sir, notice, once you finish the house and see, you will be going for a PG examination, PG preparation, but maybe short period you will be working in the periphery. Very, very important. Timely referral, but all the precautions. And if possible, you should have facility or give ASV and then transfer, because the time matters. We all remember the kid from Wayanad to Calicut. That child could have been saved if ASV was administered there. So the travel period of maybe 1.5 hours cost a life. So that is our very, very important message. I think we'll take questions from there and we'll answer that question, Virendra.
One question I have seen is, can we give half dose of adrenaline for all cases of ASV? Half dose is for a prophylaxis dose. Therapeutic dose is full dose. Therapeutic dose is full dose, 0.05 mg per kg. One adrenaline is 1 milligram in 1 ml. So 0.01 milligram per kg is 0.01 ml per kg. That gives intramuscular. That is not half dose. Half dose is prophylactic.
Virendra sir,
Yes.
I was asking whether we can give half dose adrenaline for all cases before giving AS.
Yes. You can give. That will reduce the ASV reaction is very high. 50 to 80% there will be ASV reaction. Current ASV is a FAB2 fragment. FAB2 fragment, and it is purified ASV now. So reactions are much less. But you can give ASV, but never as adrenaline, but never give adrenaline and steroid. Hydrocortisone, steroid is not required. Combination don't give. And antihistamine is also no role for prophylaxis. Only adrenaline has prophylaxis.
Okay, sir. Sir, one more that along with the WBCT, can we do PT-INR for all cases to increase the sensitivity?
Yes. If there is facility, that will increase the sensitivity. PT-INR will be abnormal before WBCT abnormality usually, but reverse also can occur. PT-INR normal, and WBCT can be prolonged.
Thank you.
Then another question: can we use calcium gluconate? Yes, in the national guidelines, calcium gluconate is mentioned for crate bite, because neostigmine and atropine combination will not be effective in snake crate bite. Calcium gluconate will stimulate the reduces the CNS symptoms, but it is only bridging therapy. If it is CNS symptoms not improved much, we have to go to ventilation. So calcium gluconate can try, it will reduces the symptoms in crate bite a little, may, not sure. That is mentioned in National Treatment Guidelines for snake bite. Any other questions, sir? I have not seen any other question.
One is that neostigmin in snake bite.
Neostigmin, I have shown the slide. Neostigmin and atropine combination. 0.05 milligram atropine, 0.04 milligram per kg. Neostigmin. Atropine, neostigmin. 0.05 milligram per kg atropine, 0.04 milligram per kg neostigmin intravenously. That you can try and wait for 30 minutes to 60 minutes for improvement. If there is 50% improvement in CNS symptoms, you can repeat 2 to 4 hourly. At neostigmin, you can repeat every 2 to 4. But that is only bridging. That will not be effective in crate bite. Cobra bite will respond with ASV. Crate bite will not respond with ASV. There, this is not effective. Calcium gluconate also is not that much effective, but you can try. Till this ventilation time, you can save.
I hope.
Should we do PTNR always with WBCT? Yes. If the facility is there, do PTNR. That will increase the sensitivity from 75 to 80%. Is with more 90-95% sensitivity will be increased.
So one question is, should we take consent before giving ASV?
ASV before giving ASV, if the parent has not given consent, we should give ASV because it is life-saving. There is no other modality to save the child. So we should give inform that it is the only life-saving measure, and without giving ASV, there is 100% that ASV can produce reactions. There is reaction, but we can treat the reactions in an ICU. That we can convince and get the consent.
So should we take consent for every
Yes.
before giving ASV?
Yes, we'll take the consent for before giving ASV because it can produce reactions. So before that, we can take consent. Informed consent we can take. But
sir, Virendra sir, one
yes.
question, sir. If they don't, because of our writings, no, if they don't give the consent, still can we give? നമ്മൾ ചിലപ്പോ ഹൃദയമെടുപ്പ് നിന്ന് പോകുന്നൊക്കെ എഴുതി കഴിഞ്ഞാൽ ചിലപ്പോ ഒരു കൺസെന്റ്
അങ്ങനെ നമ്മൾ എഴുതാതിരുന്ന പോരെ. ഹൃദയമിടിപ്പ് നിന്ന് പോകുന്നൊക്കെ നമ്മൾ എഴുതുമ്പോഴാണ് ഇവര് കൺസെന്റ് തരാത്തത്. നമ്മള് അതായത് BP ഫോള് വരാം, സ്കിൻ റിയാക്ഷൻസ് വരാം, ശ്വാസം മുട്ടൽ പോലെ വരാം, ബ്രോങ്കോസ്പാസം വരാം, അങ്ങനെ നമ്മൾ പറഞ്ഞ പോരെ. അല്ലാതെ ഹൃദയമിടിപ്പ് നിന്ന് പോകും
കൺസെന്റിന്റെ ആവശ്യമുണ്ടോ എന്നുള്ള എമർജൻസി ആയതുകൊണ്ട്.
യെസ്, ഇറ്റ് ഈസ് എ ലൈഫ് സേവിംഗ് മെഷർ.
അല്ല, കൺസെന്റ് എടുക്കണോ?
ഈ കോട്ടയത്ത് ഇങ്ങനെ ഒരു ഇഷ്യൂല്, അതായത് ഒരു എമർജൻസി സിറ്റുവേഷൻ ഇൻക്യൂബേറ്റ് ചെയ്ത് വെന്റിലേറ്റ് ചെയ്യണം, റെസിസ്റ്റേറ്റ് ചെയ്യണം, അതിന് കൺസെന്റ് വേണോ എന്ന് ചോദിച്ചപ്പോൾ ജസ്റ്റിസ് കുര്യൻ തോമസ് സാറ് പറഞ്ഞത് കൺസെന്റ് വേണ്ട, അതിന് ഒരു ഡോക്ടറെ സ്യൂ ചെയ്യാൻ പറ്റില്ല എന്നാണ് സാറ് പറഞ്ഞത്. ജസ്റ്റിസ് കുര്യൻ തോമസ് എന്ന് പറഞ്ഞത്.
ICHൽ കൺസെന്റ് എടുക്കാറുണ്ടോ ASVക്ക്?
നമ്മള്
അല്ല, നമ്മളിപ്പോ ആന്റി റാബീസ് വാക്സിൻ എടുക്കുമ്പോഴത്തേക്ക് നമ്മൾ കൺസെന്റ് വാങ്ങാറില്ലല്ലോ.
പറഞ്ഞു കൊടുക്കാറുണ്ട് സാർ. ഇപ്പൊ ഈ കേസിന്റെ അകത്ത് ASVന്റെ അകത്ത്
ആന്റി റാബീസ് വാക്സിൻ പോലെ അല്ല.
അല്ല, ഇത് ഈസ് ഓൾമോസ്റ്റ് സെയിം നോ. ഇത് നമുക്കത് പറയാമല്ലോ.
വെയിറ്റ് ചെയ്യാം.
ഇൻഫോംഡ് കൺസെന്റ് എടുത്താൽ നമ്മുടെ പാർട്ട് സേഫ് ആയിരിക്കും, വലിയ ഇഷ്യൂസ് ഒന്നും വരില്ല, അതേ ഉള്ളൂ. പക്ഷെ കൺസെന്റ് ഇല്ലെങ്കിലും ലൈഫ് സേവിംഗ് ആണ്, കൊടുക്കാവുന്നതാണ്. ലീഗലി വലിയ പ്രശ്നങ്ങൾ ഉണ്ടാവേണ്ട കാര്യമില്ല എന്നാണ് എന്റെ അറിവ്.
ആന്റി സ്നേക്ക് വെനത്തിന്റെ കാര്യത്തിൽ മിക്കവാറും കേസ് അങ്ങനത്തെ ഒരു ഇഷ്യൂ വരാറില്ല സാറേ.
ഇല്ല,
മിക്കവാറും ഓൾമോസ്റ്റ് അവരറിയും ഒരു പോയ്സണസ് സ്നേക്ക് ആണെങ്കിൽ ദർ ഇസ് നോ വേ ഔട്ട്. അപ്പൊ ഈ വാദങ്ങൾ വരാറില്ല, അൺലൈക്ക് ഡോഗ് ബൈറ്റ് കേസിനെ പോലെയല്ല. അപ്പൊ അതുകൊണ്ട് തന്നെ നമുക്ക് പലപ്പോഴും ഇതൊരു പ്രോബ്ലം ആവാറില്ല. ഇപ്പൊ ഈ പേഷ്യന്റെ അകത്ത് പേഷ്യന്റിനെ അറിയാം, കാരണം മറ്റേ ഡെത്ത് 100% ആവുമെന്ന് അവർക്കും കൂടി അറിയാം. അപ്പോ പോയിസണസ് ബൈറ്റ് ആണെന്നുണ്ടെങ്കിൽ അതിന്റെ ഓപ്ഷൻ കൊടുക്കുക, റിയാക്ഷൻസ് ഉണ്ട്, അക്സെപ്റ്റബിൾ റിയാക്ഷൻ ഒക്കെ പറഞ്ഞു കൊടുക്കുന്നു മാത്രം. പിന്നെ രണ്ടാമത്തെ വൺ പോയിന്റ് I think there are situations where we need to continue ASV with adrenaline drip. Sometimes even adrenaline single dose repetition, again, the reaction will be much more common. So
Yes.
there is the situation where you need to counsel them because already reaction has occurred. We are addressing it. We don't have any other option other than to continue ASV. The pros and cons of this thing. The chance of death due to reaction is this much. If you are not giving it, chance of death is 100%. So there is a chance of escape, saving the child, taking the risk. So we are doing that. Otherwise, the patient will be, you will lose the patient. So that is the situation where most of these discussions and this thing comes. Important.
Another situation that can occur, that we can repeat ASV, is that initial 10 vials of ASV improved the cardiac CNS symptoms. But later again, CNS symptoms can recur because the tissue fixed venom, when the free flowing venom decreases, tissue fixed venom can come back. That can produce re-envenomation. CNS manifestation can be there. Initial corrected clotting time can again become abnormal. Then you have to repeat the ASV. Initially, the child comes in shock. Then the full venom will not come. When the blood circulation corrects from the tissue, more venom will come to the circulation. So initial less bleeding time may not be prolonged. Then once the circulation is corrected, bleeding time can be prolonged.
Just like sir said, how late you can administer ASV. So how late?
If the child comes late, coagulopathy, ASV has to be given. CNS symptoms, ASV has to be given. Otherwise, no.
Maybe even after 36 to 48 hours,
Yes.
6 hours also, you have to give whatever benefit due to this thing, rather than denying the ASV just because it is late is not justified. You have to give, especially viper bites. Viper bites, the manifestation may be late. So viper bite, definitely early renal involvement is possible if you should be giving it early, but late comers also, you are justified in giving ASV because slow entry is possible. One mistake by the house agents is administration of giving too much importance to hydrocortisone. Sir has already pointed out adrenaline and adrenaline. Adrenaline is the drug in the case of anaphylaxis. There is no role for hydrocortisone, no role for antihistaminic. Adrenaline prophylactic also is justified of the dose. When you are giving IM subcutaneous, the timing will be late because subcutaneous takes maybe more than 30 minutes. IM again maybe 8 minutes to 10 minutes. So in a case, always IM, but in a prophylactic, you'll get more time. So subcutaneous will do. Half the dose will do. Gobi,
any more
voice
questions?
break, Gobi.
ഹലോ സർ നമുക്ക് ന്യൂട്രോഫിലിക് ല്യൂക്കോസൈറ്റോസിസ് ഉണ്ടെങ്കിൽ ഒരു ഏർലി മാർക്കർ ഓഫ്
Leukocytosis is an early marker. Leukocytosis is an early marker. Thrombocytopenia, leukocytosis, systemic inflammation markers.
സർ എത്ര ഏർലി ആയിട്ട് വരാം സർ? ഐ മീൻ ഒരുപാട് ലേറ്റ് ആയിട്ട് അത് ഏർലി ആയിട്ട് തന്നെ കാണാറുണ്ടോ?
Leukocytosis
സാറേ, കാരണം നമ്മൾ കാലിക്കറ്റിലെ ഡോക്ടർ ജയകൃഷ്ണന്റെ ഒരു സ്റ്റഡിയാണ്, അതിന്റെ റിപ്പോർട്ട്സ് ആയിരുന്നു. ഇറ്റ്സ് ഇൻഫെക്ഷൻ, സെക്കൻഡറി ഇൻഫെക്ഷൻ ഓൾസോ ഇറ്റ്സ് പോസിബിൾ, ബട്ട് ഇറ്റ്സ് ബിഫോർ ദ സെക്കൻഡറി ഇൻഫെക്ഷൻ വിത്തിൻ അവേഴ്സ് തന്നെ ലുക്കോസൈറ്റോസിസ് കാണാമെന്ന് അവരുടെ സ്നേക്ക് ബൈറ്റിന്റെ ഒരു സ്റ്റഡി അവിടെ നിന്ന് കാലിക്കറ്റ് നിന്ന് വന്നതാണ് സർ. അതിന്റെ വൺ ഓഫ് ദി ഏർലി മാർക്കേഴ്സ് ഇതാണ് പറയുന്നത്, ഏർലി ആയിട്ട് വരാം.
Yes, yes.
Now, if there is no more questions, I request our treasurer, Dr. Ranjit, to propose the vote of thanks. Ranjit.
Good evening all. It was an excellent and interactive session by Professor Virendra Kumar sir. and good interaction by Professor Purushottam sir and Bala sir and all other participants. So I think the session is very useful for the practicing pediatricians and house surgeons also. So we will come out with more such tips in the coming weeks also. So a big thanks to Virendra Kumar sir and Purushottam sir, Gobi Mohan sir, Shimi sir, Bala sir, and all the other participants. So have a good day. Good night. Jai Hind, Jai IIP. Thank you.
Good.
Thank you.
Thank you, sir.
Our next month, our talk will be on dengue fever. Dr. Susie Joseph. Details will be posted shortly. Thank you. Jai Hind, Jai. Good night.
Jai Hind, Jai IIP.
Thank you, sir. Good night.
Good night.